have a guest talk by Dr. Amit Sethi on the topic Occupation-Based Behavioral Activation for Developing Interventions for Chronic Occupational Dysfunctional Management. Dr. Amit Sethi is an associate professor in the Department of Occupational Therapy and the director of the Masters in Occupational Therapy program at the University of Pittsburg. He completed his bachelor's in occupational therapy from Manipal College of Allied Health Sciences, India, and his Master's of Science in Occupational Therapy from the University of Wisconsin-Milwaukee, and his PhD in Rehabilitation Sciences from the University of Florida. He is the director of the Neuromotor Recovery and Rehabilitation Lab. The focus of his research program is to understand the mechanisms of recovery to inform the development of interventions and technologies to improve motor functions in adults post-stroke. His research is funded by the National Institute of Health, USA, and he has published in several peer-reviewed Tier 1 journals. I invite you, sir, onto the stage.
All right. Good morning, everyone. Can you hear me? Yes, I think. Thank you, AIOTA, for inviting me for this presentation. I think I am a little loud, so I'm going to keep this mic a little back. Okay, so my name is Amit Sethi. I'm an associate professor and the director of the Master of Science program in Occupational Therapy at the University of Pittsburg. I did graduate from Manipal, and as Dr. Chauvin mentioned earlier, I am from University of Pittsburg. I did see few people using scales that were developed at the University of Pittsburg, which I'm quite happy to see that they're being used. So the topic of my presentation today is occupation-based behavioral activation for developing interventions for chronic occupational dysfunction management. And the primary focus of my research is in developing interventions for stroke, primarily the upper extremity functions, the hemiparesis of the arm and hand, and so we are developing interventions for that. So I'll be using that as a model for talking about occupation-based behavioral activation in that. And so my research has been funded by several institutions across the United States, primarily being the National Institutes of Health, which is the federal or the central government, like you have the, in India, the central government, so they primarily has funded my research. And some are also funded through the private institutions as well as the University of Pittsburgh grants as well. So as I mentioned, the focus of my research is to develop interventions to improve upper extremity function after stroke. There are two main things that we're using in my research program. The one is non-invasive brain stimulation. I'm not going to talk about that, but this involves transcranial magnetic stimulation and transcranial direct current stimulation or electrical stimulation. So if any of you are interested or want to know more about it, please feel free to contact me. You can contact me on LinkedIn as well. The other technique that we're using is part of my research program, which I'll be talking about today, is behavioral activation. So with that, let's talk about the outline for today's presentation. I'm going to talk about that why is it challenging to actually see real-world upper extremity hand use after stroke, which means that even though patients get treatment in the hospital or in the clinic to improve their upper extremity function after stroke, they still not are able to use their weak hand at home when they get discharged or when they are discharged from therapy services. I'll talk about the principles of behavioral activation, and then I will illustrate how you can use these principles of behavioral activation to develop an intervention to ameliorate or improve the hand function after stroke. So if you sleep for the next 15 minutes, this is my take-home message. I always like to put it first. So occupation-based behavioral activation is a very useful intervention to establish healthy routines and engage individuals in meaningful occupations to change chronic behaviors, which as occupational therapists we often use. We are treating chronic behaviors. Occupation-based behavioral activation primarily includes 4 or 5 of these ingredients. goal setting, activity monitoring, activity scheduling, problem solving, and self-rewarding. And then occupational-based behavior activation can be used to promote real-world upper extremity use and functional independence after stroke. So this is my take-home message, which I will repeat at the end as well. So what is behavioral activation? Behavioral activation was originally developed to promote improvements in mood and frequency of engagement in pleasurable activities in individuals with chronic depression. It has been a well-known treatment that has stemmed out from the psychology literature and has been established effectiveness of this in chronic depression. It has also been used to improve mood, motor function, and participation among people with chronic diseases other than depression, like brain injury and dementia as well. And behavioral activation, what it does is it's basically one of the best approaches to establish healthy habits and routines in these chronic conditions, which as occupational therapists, we are often trying to improve the routines and habits of our patients, right? Getting them back in their daily life and as much as possible increasing their functional independence. So, and as I mentioned, meaningfully engaging individuals also in their healthy routines. So I'm going to show you an application of how we have used occupation-based behavioral activation in improving chronic learned non-use after stroke. So what is chronic learned non-use? So we're going to learn more about that. So upper extremity impairments are very common after stroke. This is nothing new to you. And 15 million individuals experience stroke every year worldwide, approximately 2 million cases each year in India, 700,000 each year in the US, and it's increasing every year, right, these cases, as well as it's an alarming #1 cause of permanent disability worldwide, stroke. Up to 80% of these individuals exhibit arm and hand impairments in one hand, and as you can see in this video, this is one of our patients in a research study. She's trying to open the simulated key opening task using Wolf Motor Function Test, which is a standardized assessment, and you can see that she's really struggling to open that with the disability, right? I'm sure all of you have seen patients like this who exhibit such impairments, and these are these individuals who have limited functional hand use. And so when they stop using their hand over time, they start depending on their other extremity, on their other hand, right? And this phenomena causes learned non-use, where they stop using their weak or the paretic hand and they start using their non-paretic or their unaffected hand after stroke. As occupational therapists, we want to make sure that we are improving their function of the weak hand or the paretic hand, right? So this learned non-use behavior causes a huge problem in rehabilitation because we're trying to break the barrier that, okay, do not use the unaffected hand more, but start shifting the balance from unaffected to the affected hand. So the goal of upper extremity rehab post-stroke is to increase independence, increase productivity, and increase function. So what's the best treatment out there right now for improving hand function post-stroke? This is another, like everybody knows, repeated task practice, or also sometimes known as constraint-induced movement therapy, right? That you constrain the hand of the less affected or the unaffected hand after stroke, and then you force the use of the weak hand over and over again in daily tasks with that, right? So we know that this works, but the problem with this is that in existing repeated task practice intervention, therapist monitors and schedules the use of the weak hand at home. So the therapist will tell, okay, do these many repetitions, do this, and then they create a home exercise program and they deliver the whole program to them. The therapist also tries to identify the barriers of using the weak hand in daily tasks at home. So when there are problems by the therapist, like by the patient, that they may come back and say that, oh, you know what, I'm not able to do these. You've asked me to use my weak hand at home, but I'm not able to do that. The therapist is the one who's telling them all the solutions for that. So the therapist is basically the point of contact or the person who's dictating everything, right, for the therapy. So because of this, there is lack of generalization of skills that are learned from the clinic or the research lab to the use of the weak hand in daily life outside the clinic or the research lab with that. So this has been quite well known and has been studied. And so how can we, and they've shown quite extensively in the last 5 to 6 years that when patients were in multiple randomized control trials, when patients actually did perform interventions, they improved in their hand function in the lab or in the clinic, but they did not use that as much when they were left alone at home with that, right? So that has been already proven. So the next step is how can we promote generalization of skills of hand function outside the clinic or a research lab? So the first thing is there to increase the awareness of the importance of using the weak hand, right? Weak upper extremity in daily tasks. And motivational interviewing is one of the best strategies for doing this. You make sure that the person is in charge of their therapy. They have the onus of that, their rehabilitation. You increase the insight of them with that. I think that is one of the initial things, but that's not the main thing. The main thing constitutes of these components of behavioral activation, and these are the components of the behavioral activation. The main difference is compared to the initial approach where I told you that it is not a therapist-guided, it is not a therapist-directed approach, rather it is a therapist-guided or a client-driven approach. And I'm going to show you some examples of how we do this in practical. So you can even go tomorrow and start using this in your clinic. So the first component is goal setting, which I think to all occupational therapists is not new. Eliciting goals should consider activities that our clients need, want, and are expected to do. And you can use any of these standardized assessment measures like COPM, the Canadian Occupational Performance Measure, or the activity card sort to develop personalized, meaningful goals for your clients. The next thing is activity monitoring. So how do you monitor the activities? So now you have set the goal that, okay, I need to use my paretic hand or the weak hand in doing this activity, but outside the therapy, when I'm doing at home, the client, how do you do that? So we've created, so there are two ways you could do this. There's a low-tech way and a high-tech way. So the low-tech way is this example that I'm showing you on the screen here. So you can see that there's this activity monitoring worksheet. So it has these columns. Okay, today's date, time, what activity did I perform, and which hand did I use? Right, left, or both hand, if it's a bilateral or bimanual activity, right? And how do I feel? Did I struggle with using my paretic hand, or was it comfortable using that? And so you have to, as a therapist, you can help create some of these worksheets for your clients with that, so they can document it. The other, of course, more technology method that we've used in our research and other people have used is also an accelerometer. Accelerometer is nothing but like in your Fitbit or your smartwatches, your Apple Watch, Samsung Watch, you have these, and they can measure the frequency of use of the hand. And I wanted to show you how this can be used. So on this, here you can see on the left-hand side, this is a plot that you can use. So there is, on the left-hand side, there's the non-paretic, and on the right-hand side, there's paretic. So in non-disabled adults who are healthy controls, like healthy adults who do not have stroke, you see there's an even distribution of data points on the right and the left side, right? It's a nice, like a bell-shaped curve that you see. So that means that a healthy adult who doesn't have stroke uses both his or her hands equally every day with that, okay? However, when somebody is after stroke, you'll see that on the next one there, the bottom line is non-paretic and the right one is paretic. You'll see that the shift is happening towards non-paretic more on the left side, right? It is skewed towards left. So that can tell that, okay, you know, now the patient is using more of their non-paretic or their unaffected side compared to the affected or the paretic side with that, right? So so we would want to see that after treatment, that shift from the left goes to the right, or it becomes like this, where patients are using more similarly, a symmetrical pattern over time, that, right? So this can be used as another monitoring tool for using accelerometer. The next thing is activity scheduling. This is an important, very important aspect. Is like we often tell patients, okay, you know, you do this at home, but how are you going to do it and when are you going to do it? That is very important. So making sure that you're talking to your clients and then identifying times in their day when they can do this, right? It sounds very simple, but it is not simple. Because as we know, like even like for any other chronic issue like weight management, for example, if you do not carve out time, when do you want to exercise? How am I going to eat my meals properly with that? That is not going to happen with that, right? So it's very critical to talk about that and identifying those times with your clients. The next thing is problem solving. So in the previous approach I showed you, in the therapist directed approach, the therapist is the one who is telling, okay, this did not work at home and why did it not work? But here the approach would be that you ask the client themselves, why did it not work? Make them in charge of their recovery and rehabilitation, and use an active problem solving approach rather than telling them that what they should be doing. The next is the self-reward. So when you were able to use your weak hand or the paretic hand in your day-to-day task, how did you reward yourself, or how will you reward yourself? Like, celebrate that. Because those small celebrations or small achievements do make an important role with that. And then, of course, you keep on practicing this over and over again. So those are the main components of behavioral activation. And then here's a comparison of on the left-hand side, I show you here the therapist-directed approach versus the therapist-guided behavioral activation approach. So the step one in monitoring hand use at home, in the therapist-directed one, the therapist is the one which is monitoring whether the patient is actually adhering to what they have been told by the therapist or not at home. Versus in the therapist-guided behavioral activation, the therapist is monitoring the frequency. Are they actually using it or not? Whether you use a low-tech way or a high-tech way, accelerometer or those worksheets. The next one is the scheduling, the activity scheduling, right? So the therapist is telling in the therapist-directed one, you need to perform these many repetitions, like 20 repetitions of this activity 3 times a day. The therapist-guided approach is like the therapist is making the patient in charge. When do you think you can do this occupation during your day? Tell me the time. So you see, it's a shift in mindset. It sounds very simple and subtle and obvious, but you will see the power of making that onus on the client themselves. The third one is the problem solving, and the therapist-directed ways. These are the barriers. You were not able to use your hand at home like this, so these are the barriers, and this is how you should improve it. But in the therapist-guided way, the therapist is asking the patient, try this occupation. What did you think about this? What were the barriers that impede your performance on this occupation? And then how are you going to solve them with that, right? So making them again the in charge. Step 4 is self-reward. The therapist is telling them, you did a great job by cutting food with your affected hand or the paretic hand. And the therapist-directed way, guided way would be like, I ate with my affected hand, so I'm going to reward myself by doing this with that, right? So, and then in the iterative practice, the therapist is telling them, I'll tell you how to address the next problem. So they did, if they were successful in using their weak hand on one task or one occupation, then how the therapist is going to tell them, do it for the next one. However, in the therapist-guided one, they're going to tell, how will you apply this to the next problem or the next task with that? So it's again the subtle difference between the two. So in a nutshell, again, these are some of the principles for occupation-based behavioral activation. It's a useful technique to establish healthy routines and engage individuals in meaningful occupations to change chronic behaviors like chronic learn non-use after stroke. And this includes goal setting, activity monitoring, activity scheduling, problem solving, and self-reward, and can be used to promote real-world upper extremity use and functional independence after stroke. Thank you for your time and attention, and I'll be happy to take any questions.
I just wanted to know one thing. You mentioned about self-reward. So, do the therapist help the patient in suggesting the ways they can self-reward themselves?
Yes, yes, you can. So again, the main focus is you're not directing them, but you're taking a more passive or a suggestive role, as you said,
Okay.
with that, right?
So
yeah.
I would request, can you share some examples of self-reward which you had seen, the patients had used, which are common with them?
Yes, well, so like going out for a movie, for example, or eating their favorite meal.
Okay.
Anything like
Which they like.
Which they like, yeah.
Right,
Again,
right,
it's upon them, right? What you want to do. So if you think about it from the principle of weight loss management,
Yes.
people, what do? Oh, I have a Sunday. If they follow it their entire week, some strict dieting, right? And they're going to say, on Sunday, I'm going to go all out and I'll eat whatever I want. That's my cheat day.
Cheat day,
Something like that.
Right.
So, yeah.
Right.
Yeah.
Thank you so much, sir.
You're
Thank
welcome.
Good morning, sir. It was great listening to you. I just have a question. Do you have any randomized control trials happening in order to prove that therapist-guided approach is better than therapist-directed approach?
Great question. Yes. So at my institution, our Associate Dean of Research has completed one study. It's a phase 2 randomized control trial with about 200 patients post-stroke, where they have shown that the therapist-guided approach is much superior and effective compared to therapist-directed approach, not for motor recovery, but for cognitive and mood recovery after stroke. So her main focus is that. We conducted phase 1 study, a preliminary efficacy study at this point, where we have also shown this as well in motor recovery post-stroke with that. So we've applied for funding to go to the next step, phase 2 for this study, yeah.
We'll be waiting to see your results.
Thank you.
Thank you. Thank you so much.
Yeah, hello. So this is Muthulakshmi. I have a question for you. And when you have mentioned that iterative practice, that is repeated practice, that is what our clients will actually have a real challenge, right? So can you please throw some light upon the self-motivation? What would you suggest primarily?
So the great question. So I think the self-motivation comes in from the aspect of the first part, developing insight into that, right? So again, I compare this to weight loss, for example, right? Because behavioral activation has been used in chronic depression and weight loss management a lot. So I don't know in India or if there are apps or not, but in US there's a huge market right now that they have developed these apps on smartphones, where one of them is called Noom, N-O-O-M, and it is basically using nothing but these principles of behavioral activation. And the main focus there is that you want to make sure that the person themselves is the driver, right? So unless and until the person thinks that I need a change now, or I am ready for this change. So there are these several theories of change that have been proposed over the last few years, and the first aspect in changing a chronic behavior is readiness to change with that. So that readiness to change is the most important thing with that. So no matter what you do, if the person is not have even adopted that idea that I am willing or I am ready to change, no matter what you do down the road, it's not going to work with that, right? So I would recommend you look into that literature of readiness to change and use some of the principles from that, some theories and principles from that, and then develop something. And there are published guidelines also on readiness to change, on how you do that. And so one of the ways I think we have done it with is COPM, right? So we do an initial interview with our clients, patients, and then you do the COPM and what is meaningful for them, right? And why do they want it? So we go to the next level and we try to investigate why they are not doing this and what is really meaningful for them, right? The goals with that. So that is an inherent component in there is readiness to change, but also I would recommend read more on that. Yeah, it'll give you some guidelines. Great question. Yes, sir.
Yeah, hi. picking up from the question that she had presented, I mean, iterative practice. I'm really fond of this word iteration because it's a very prevalent terminology used in the domain of assistive technology. Now, coming in the context of this particular presentation, are there certain parameters when the therapist decides that now we have to undertake an iteration?
Yes. I think the main parameters are for your activity adaptations, right? Generally, how we grading what we've been learned in basic, like first year of occupational therapy school, bachelor's in OT is like grading up or down with that, right? So as you become better at something, as you keep doing it again and again, then you move to the next goal with that, right? And so we use the same principles again. We've created these checklists, and the therapist is actually monitoring how much or when, how they need to adapt the task at home or in therapy as well. Yeah, so grading up and down is basically the things that we're using. Basic 101 that you taught me, I remember as a bachelor student in OT, yeah. Those are the same things that we're using, yes.
Thank you.
Thank you.
Can I just ask?
Oh, yes, sir, please.
Hello, Dr. Sethi. That was a very interesting presentation.
Thank you.
What I really like to ask is that, how do you see the difference between the behavior activation versus behavior modification? Because in a way, when you are approaching the proximity in functional tasks by, for example, goal setting, this is one of your first things. So do you really trying to say that by goal setting, are we trying to change the behavior pattern, or is more of a activation patterns? So there I'm really trying to see the difference between behavioral activation versus behavior modification. We use behavior modification, I think, no way.
Yes, so behavior, so great point. I think the main goal setting is important for, it's again for readiness to change, right, from that principle. That unless somebody is willing to, like, why would I do that, right? So for example, like if the patient really wants, like some of the patients, they have told that I want to play with my grandchildren with that. So that is the goal that they want. And in order to play with them, they need to make sure that their hand is working with that, right? And so that is the main key for them. So they always keep that at the back of my mind, and that becomes their main thing. That if I gain function back in this hand, I will be able to play with my grandchildren with that. So that is how we have used that as goal setting as an important element of that, yeah. So again, not the therapist directing them that this is how you should do, but the goal is coming from the client again, right? Again, that is something that we learn in OT school, but at least in the US, I don't know, it's been a long time I have practiced in India, but at least in the US I've seen that sometimes because of the insurance issues and there is pressure from, for the therapist to discharge the clients very quickly from their hospital setting, we often do not focus on client-centered goals in the initial phase of recovery with that post-stroke. And so that is why I think this goal setting needs to be brought up again, that it's important with that, right? And it's important for activating the behavior, to change the behavior with that, right? Yeah. That's why it's the first thing in the first element. I hope I answered your question. Thank you.
Thank you, sir, for your presentation. I would like to call Dr. R.K. Sharma, sir, to felicitate Dr. Amit Sethi, sir.